Welcome everyone to the Emedica GP update. So this is the launch sessions, first session, November 2024. We're hoping to hold these every couple of months. Okay. So the idea is that this is something that's going to be helpful whether you're in GP training at ST1, ST2, or ST3 level, or if you're post CCT looking for an update and things to help you with everyday consulting. For those who haven't met me, a brief introduction. My name is Muhibbur Rahman. I'm a portfolio GP. So the focus today is going to be on drug safety. And so, our theme in terms of our clinical update will be drug safety alerts, specifically going to focus on MHRA alerts. So, the MHRA is the Medicines and Healthcare Products Regulatory Agency. So what they do is they're the ones that when drugs have been through phase 1, 2, 3, and so on trials, to finally get a license to be able to be prescribed in the UK, the MHRA has to authorize it. But they also, when you fill in a yellow card, if someone has a serious side effect or something like that, it goes to the MHRA and they monitor drugs and also medical devices. And by doing that monitoring, that's when they can see, okay, there's a trend, this is a new side effect that didn't show up in the previous trials. And then when that happens, or sometimes drugs that have been established for a long time, if they see a trend, they will put out a drug safety alert. So they sort of publish, every so often they'll say, publish, these were the alerts in the last few months, but when there's a specific drug that they see something important that has an impact on patient safety, they will put out an alert sort of at any time. They'll also publish drug recalls, and sometimes just through their monitoring program, they'll publish something that maybe was already known, but as a reminder, a drug safety update. Okay, so what I've done is I've looked through MHRA alerts from 2024 and 2023 and picked out a few key ones that I thought that we'd discuss today. So we're going to look at these drug safety alerts. So 7 things that we're going to look at, and this will be the main part of the session today. And to keep it interactive, what I'm going to do is for some of these, before I cover, if you like, the actual update, I'll share a question, because for those of you that are in training, this will give you a flavor of the kind of question, because drug safety alerts often come up in the MRCGP AKT. But those of you that are going to sit the MRCGP SCA, again, you might have a patient who's presented with one of the key side effects. And so knowing about that, and of course, for those of you that are post-CCT, it's useful for us just to stay up to date, right? Because we might have been prescribing something for a long time, see a patient. If you're not aware that there's been a recent alert, you might not realize that we need to change our practice, okay? So let's start with a question. So I'm going to show you a question, give you about 55 seconds or so to have a look at it. Then I'll launch a poll just like I did here. Please select an option from the poll, and then I'll do some teaching around it. I won't do a question for every one of these topics, just for some of them, just to keep it interactive, okay? Here we go. Okay, that's time. Please select your answer in the poll. While you're selecting your answer, just a quick recap of the key features here. So, this patient's presented because they're getting muscle weakness and fatigue, which is getting worse. Note that it gets worse as the day goes on. And some of the specific things, holding up their head, brushing their hair, even just chewing, doesn't seem like that strenuous, right? And when they rest, it improves a little bit. No recent infections or anything, no family history of note, but they were started on a statin 6 months ago. Okay, great. So well done. Most of you got this right. The correct answer is E, myasthenia gravis. Okay. The other 2 popular answers were giant cell arteritis and Guillain-Barré syndrome. A couple of things that make these less likely. you know, when it says what's the single most likely diagnosis, for those of you doing exams, bit of exam technique, and that is that sometimes more than one thing can clinically fit the picture. And if more than one thing clinically fits the picture, the one that's the most likely is the one that's more common. Now, sometimes something quite rare will still be the single most likely because it fits better than any of the others. So what makes giant cell arteritis less likely for this one? What would be a really important feature that if it was there, that might make you think, okay, you know what, maybe I'd be leaning more towards giant cell. So a couple of things. So one is that there's no pain, there's no headache. They had headache, and then 52 is quite young. You can't get it at that age. But you know, if they were sort of late 60s, 70s, and they had a headache, okay, then I'd probably lean more towards giant cell arteritis. Okay. And then what makes Guillain-Barré less likely? When do we typically see that? And what's the other name? What's it sometimes called? So often, before someone has developed a feature of Guillain-Barré, is that they would have had an infection recently, right? They've not had any of that, but it's also known as the ascending paralysis. It tends to start low down and then spread upwards, right? The weakness starts lower down and then spread upwards. They've already got it like chewing during meals. Doesn't mention anything about their lower limbs. Do you see? What feature might make us think, oh, I'll be thinking about Horner's? That's not mentioned here. Yeah. So eye symptoms like ptosis, right? And then MS, what kinds of things might we see? Because in MS, you can often get very tired, but you wouldn't necessarily have things like difficulty when you're chewing meals. What you might see though is, you know, like sometimes you might get things like changes in vision. You might get things like that it comes and goes. They have periods where it gets better, then periods where it gets worse, and so on. Okay. So why does myasthenia gravis fit? It's not just the symptoms. One of the key things is atorvastatin. Remember, today we're talking about drug safety, right? So one of the recent MHRA alerts was relating to statins, that there's been a small number of cases of either new onset or aggravation of existing myasthenia gravis with these statins. So atorvastatin, the most commonly prescribed statin, is one of them, but all of these were mentioned. So it's now recommended that when you're first prescribing someone a statin, that you make them aware of the symptoms of myasthenia gravis, and that if they get any of those symptoms, to get help. What's the other key side effect that we tend to warn people about? What's a relatively common but important side effect with statins? Yeah, rhabdomyolysis, right? So you warn them about getting sort of muscle aches and pains, right? But in terms of myasthenia gravis, it's rare. It's an autoimmune long-term chronic condition. So what you get is this weakness. So voluntary muscles, so things like eye movement, facial expression, speaking, swallowing, limb movement, even breathing. So you can get a range of symptoms. So it can affect the eyelids, you can get sort of double vision, you can get simple things when they're repeated, they get sort of extreme fatigability. So chewing, chewing 4 or 5 times, suddenly they're really tired of it. Speech disturbance, okay, weakness of the limb, shortness of breath. And there are a few other drugs that have shown an association with myasthenia gravis. So some antibiotics, so fluoroquinolones, macrolides, aminoglycosides, 3 different types of antibiotics, and then beta blockers. Okay. Anyone know the test for myasthenia gravis? Or one of the tests that we can do for myasthenia gravis? Like if you suspected it and you wanted to do the test for it. The tensilon test. Yeah, well done. So get them to repeat the same phrase. A good one is 99. Okay. And you count how many times they can do it. 99, 99, 99. Because they get that fatigability, you count how many times, then you give them the tensilon, and then you repeat it shortly afterwards, and you see that the number will improve. And so then you've confirmed the diagnosis. Okay. So you'd refer them for, testing in secondary care. Okay, let's do another question. Anxiety. Okay, that's your time. If you'd like to select an answer, please. While you're doing that, just a reminder of the scenario. So someone who's 42 and they've got anxiety, confusion, and vivid nightmares. So she remembers exactly what happened. It's distressing even through the day because of these nightmares. And what we see is that a couple of days ago, we were worried about pyelonephritis and they were prescribed Cipro. No past psychiatric history. Examination, they're well, but there's agitation. So no other abnormal findings beyond the agitation. So what's the most suitable step in management? This one, nearly everyone's got right. So well done. So D is the correct answer. Stop the Cipro. Think about a different antibiotic because what you don't want to do is just stop the Cipro and you're not dealing with the pyelonephritis. That could make them seriously unwell. All right. Why is that? Because ciprofloxacin is of the class of fluoroquinolones. And so psychiatric reactions have been seen with this whole class. So think about confusion, disorientation, anxiety, depression, psychosis, suicidal thoughts, even attempts at death by suicide. It can affect any of the fluoroquinolones, but these are the ones specifically mentioned in the MHRA alert. Okay. And, of those, if you think quite commonly, we prescribe ciprofloxacin in GP or levofloxacin. Okay. And we should advise patients that if they get any new mood-related symptoms, because you can get these things in patients without any previous psychiatric history, that they should get medical advice. And if they get suicidal thoughts, they should just stop and get urgent medical advice. And we already mentioned that actually it's already been known with quinolones that it can also cause myasthenia gravis. But the other big one is tendonitis and tendon rupture, which condition where Cipro used to be the first line drug, is it no longer recommended as first line? Anyone know? Chronic prostatitis. Yeah, absolutely. Because of an MHRA alert, because in chronic prostatitis, they may be on medication for longer term, for a couple of months. It's not recommended because of this risk of tendon rupture. Whereas in acute prostatitis, because it's a shorter period, it can still be used. Okay, good. So let's do a question on rash. I've launched the poll. So while you're selecting your answer, just a recap of the scenario. So this 55-year-old patient, they've presented with a painful red rash that's blistering. You can see it's on the forearm and the back of their hands. And it started while they were on holiday in Spain. They've got a history of rheumatoid and psoriasis, and they're on regular medication. And you can see that they've not changed their skincare products. They're taking their prescribed medications, as they should be, fully compliant. So what's the most likely cause? You can see there's a range of medications there. Slightly more challenging question, this one. So there's a much bigger spread of answers. All of the options have been picked. Roughly sort of fifth, just under a fifth, just under 10%, and about 40% picked methotrexate, which is the right answer. So although that was the most popular, more people got this one wrong than right. Okay, bigger spread compared to the last one. And again, there's been an MHRA alert specifically about methotrexate-associated photosensitivity reaction. So it can cause phototoxicity, it can cause very severe sunburn, rashes, which can be blistering or papular, it can cause swelling, and very rarely it can lead to such a bad reaction that then it leads to a secondary infection. And there's been 1 or 2 cases where it's actually ended in death of the patient. So one of the things is to advise patients when they're on methotrexate. Now, normally methotrexate will be started by the rheumatologist, right? But often under a shared care agreement, we'll follow them up to do some of the blood monitoring, for example, Okay. And so, if you see them and you notice something, well, they might mention a rash, just knowing that if someone's on methotrexate and, they present with a rash or just mentioning a skin condition, it's just worth taking that bit of history and just reminding them of this, that they should try to reduce sun exposure where possible. If they are going to go out in the sun, they should use high sun protection, so high SPF sunblock. And then the other known issues, can affect the liver. You can get methotrexate-associated liver dyscrasias, which is one of the reasons why, we monitor renal function because it can affect the kidney. We monitor FBC because it can cause problems with that, but also LFTs. And that's one of the more common things that we pick up in monitoring is that with methotrexate, the liver function can go off. If they under advice of the rheumatologist, they'll be told to come off the methotrexate for a little bit. Sometimes if their symptoms of their primary disorder, why they're having the methotrexate in the first place, like the rheumatoid is flared up, they'll have, something like steroids to deal with those symptoms for a bit, just so that their liver's rested. Stay off the methotrexate for a bit, and they'll be restarted, and then we'll start monitoring their bloods again. Okay. Right. So do you want to talk a little bit about the next drug rather than have a question? So Finasteride. One of the things that's been picked up in the MHRA monitoring is that there seems to be an association with sexual dysfunction, low mood and depression, and even suicidal thoughts. And what's particularly of note is that sexual dysfunction can persist even if someone stops a treatment. It can continue to be an issue. So it's something just, we should be counseling the patients about. But also just finding out, like, if before you start prescribing someone finasteride, have they got a history of low mood, or have they had depression in the past? Have they got suicidal ideation? Because if they have, because it's associated with either bringing that on or making it worse, it's probably better to look for an alternative. And to warn patients that if they do develop low mood, depression, or suicidal thoughts, that, they should contact their doctor urgently. And you can give finasteride for 2 different indications, right? It can be given at a dose of 1 milligram, brand name Propecia, for male pattern hair loss, right? So if they're taking it for that, they should just stop immediately. And that's because the underlying condition that it's being treated for isn't something that if they stop the medication, it's going to have a sudden impact on their health. Whereas finasteride at 5 milligram dose, Proscar is the brand name, that's given for BPH. If they develop sort of, symptoms of low mood with that, they should get urgent advice. Because with that, they might not need, depending on how severe it is, they might not need to stop it immediately. It might be that we need monitoring. Whereas if they had suicidal thoughts, you'd want to stop it and make sure that they're seen quickly, right? Okay, let's do another question. Key things in this question: this patient's pregnant, they're 20 weeks in, so about halfway. It's a healthy pregnancy, young patient, and they've got back pain. And that's impacting the activities of daily living because it's causing, there's some swelling and some stiffness. And you can see that before they were pregnant, they had a history of previous episodes that resolved with naproxen and no allergies. So what's the most appropriate treatment? So the key thing here is that this patient's pregnant. The correct answer is A, paracetamol. Now, that was the most popular answer. Of those that didn't pick that, a lot of people picked ibuprofen. That was the second most popular answer. Okay. And actually, a few years ago, a lot of people might have said, well, for a musculoskeletal type pain, generally NSAIDs are better, more effective than paracetamol. And so they might have prescribed ibuprofen. I might have even prescribed it. What was the cutoff when we generally say not to use NSAIDs in pregnancy? up until the recent update. At what point would we say, it's better to avoid NSAIDs? Generally, once you're well into the last trimester, right? Particularly in the old sort of guidance, it was once you're 28 weeks onwards. But this latest update, has changed that. So historically, NSAIDs were contraindicated 28 weeks onwards. The reason for it is that it's associated with all these risks. So premature closure of the ductus, renal dysfunction in the fetus, prolonging maternal bleeding time, and inhibiting contractions during the labor, making that more challenging and difficult. And so in terms of the drug, really, it's a class effect, any NSAID really, but particularly mentioned ibuprofen, naproxen, diclofenac. But this latest data highlights that actually there's an increased risk when it's used from 20 weeks onwards. And what they found is that specifically prolonged use even from 20 weeks, so that's still in the second trimester rather than the third, isn't it, at 20 weeks, it can cause reduced fluid because of fetal renal dysfunction. And then it can cause constriction of the ductus, which can lead to heart dysfunction. And actually, not only do they recommend that we don't prescribe it from 20 weeks, but we should advise patients don't buy it over the counter. And that if anyone had sort of been given an NSAID for several days or longer, at any point after 20 weeks, we should monitor them for oligohydramnios. Okay, so they might need additional scans to look for fluid levels. Okay, so well done. Most people got that one right. Some of you might have got that right just because, even though we would say that ibuprofen should be avoided later on, paracetamol is relatively the safest option anyway in someone who's pregnant. So you might have picked that and not known about that update. So it's good that we also cover the update. Okay, let's do another update, and then we'll do one more question, I think, and then we'll talk about some consulting skills, and then I'll allow some time for questions towards the end. So the next one really is quite topical. So, GLP-1 receptor agonists. So, these are used and licensed for two things: type 2 diabetes and obesity. So there's 5 different ones that are available in the UK. Some of them have different brand names, which are licensed for different things. So dulaglutide, brand name's Trulicity, that's only licensed for type 2 diabetes. And often this comes, sort of at the third or fourth stage. So, you'd have someone on metformin, then you might add one of the other classes like a gliptin or, one of the other ones that come there. And then when you get to the stage beyond that, you might bring in one of these. Exenatide, so brand name Bydureon, again, that's only licensed for type 2. Liraglutide, the 2 different brand names are licensed for different things. So Saxenda is used for weight loss, but we don't prescribe it in primary care. It's only recommended in the guidelines to be prescribed in secondary care, in sort of tertiary level weight management, level 3 weight management setting. Okay, and Victoza, that brand name of the same drug, liraglutide, that's used for diabetes. And then lixisenatide, the brand name's Sulicra, that's only really used in combination with insulin glargine. And then the other one, which I think is really probably the one that's been in the papers a lot, and sometimes patients might come and ask us about semaglutide. So we have, Wegovy, Ozempic, Rybelsus. So Wegovy is licensed for weight management, Ozempic and Rybelsus for type 2 diabetes. Rybelsus is the relatively newest brand name. That's a black triangle. Anyone know what if you, in the BNF, if you see a black triangle next to a drug, an inverted black triangle like this, what does that mean? What does a black triangle drug mean? For those of you sitting in the AKT, this actually could come up in the admin domain. Yeah, well done. So a black triangle drug means that it's a relatively new drug and that it's still, if you like, in its enhanced monitoring phase. So, when do we normally fill in a yellow card and send it to the MHRA? Usually if someone's had like an anaphylactic reaction or, really bad reaction, shut down their kidneys and they've ended up in hospital, serious reactions. You wouldn't normally fill in a yellow card if someone just had a bit of stomach upset, or they had a mild rash that cleared up quite quickly. But if a drug's got a black triangle next to it, even minor side effects should be reported, because essentially this is an extension of the trial that was done in sort of strict controlled experimental setting. This is like, it's in broader use now. They're still monitoring to find there might be some side effects that the trials were too small to pick up. And now we want any side effect, we want to, so we can at least see, are they very common, less common, rare, and so on. So a black triangle drug, any side effect, even minor reactions, we should report using the yellow card. Okay. And then the other one, Mounjaro, the brand name, that's also a black triangle drug. That is tirzepatide, which is actually a combination drug. It is a GLP-1 receptor agonist in combination with this other class, a GPRA, which is got a really long name, glucose-dependent insulinotropic polypeptide receptor agonist. Okay, so this actually hasn't got insulin like this one. Sulico's got insulin glargine with lixisenatide. This one's got this new type. So, but this one, as you probably see, this one that you sometimes see in the papers, that sometimes patients want to get hold of privately for weight loss. So what are the issues with GLP-1 receptor agonists? The most common side effect, about 10% of patients will have GI side effects. Now, in a lot of those patients, it's relatively mild. Some nausea, some of them will have vomiting and it settles. A lot of patients, when they start metformin, right, they have GI side effects, nausea, vomiting, diarrhea, very common in the first few weeks, and then it often settles. However, a small number of patients on GLP-1s have had very severe dehydration to the point that it's essentially caused a kidney injury enough that they've ended up in hospital. And very recently, you might have read in the paper, there's been 1 or 2 deaths that were attributed to GLP-1 receptor agonists. Less common side effects, but things that we need to make patients aware of, that if they get, for example, sudden onset stomach pain and that's associated with vomiting, especially if it goes to the back, is that it can cause gallstones and lead to pancreatitis. The other thing is that when it's used for weight management rather than its other indication of management of type 2 diabetes, it can cause hypoglycemia in patients who are non-diabetic. So it's important that patients that are on it are aware of what kinds of symptoms to watch out for that might indicate that they're having a hypoglycemic incident. And then the MHRA also works with, there's a body that looks at fake drugs. And there's been some falsified medicines, they look like a Mounjaro or a Wegovy. They've been sold for weight loss by unauthorized channels, but some of them actually had insulin inside them. And so then the risk of a significant hypo is much more, right? And so the other thing is that, again, there are some cases where it's been picked up that it's been misused outside of what it's been studied and licensed. Because even when it's used for weight loss, it's for patients who are obese, right? And they've got increased risk factors. Some people are using it just for aesthetics. They're not even overweight, never mind obese, but they're getting hold of this medications in an unauthorized channel. And then, there's significant risk. I don't know if any of you read, there's actually a recent study in the Lancet, and it's been reported in some of the papers. They're looking at that while it's had very good results in terms of weight loss and subsequent reduction in cardiovascular risk if patients were significantly obese and therefore at increased risk. But in some patients, there's also been seen muscle loss. And that's one of the things that's being studied now. Okay, good. Let's do maybe one more question, and then we'll move on to some consulting skills actually related to this, and then a practical consulting skill and questions. Now, this one, please pick two, okay? While I give you a couple of minutes to do that, just a quick read through. So we've got a couple of important things in the history, that this patient is 33. She's got asthma. And what she's presented with is that she's had frequent migraines that are causing disability. She's not able to go to work. And that's why she's requesting prophylaxis with specifically topiramate, because she's already tried amitriptyline. That's not helped. Now, topiramate is known to be teratogenic, right? And there's a recent update that as part of the discussion, if someone of childbearing age, even if they're not actively trying to get pregnant, they're of childbearing age, and 33-year-old patient is, that they need to be in a pregnancy prevention plan as part of you being able to prescribe it to them. So part of that is to be on highly effective methods of contraception. So what you're picking is two options here where on their own, they would be considered highly effective in this context. Okay. Now, for those just doing this, because the biggest proportion of people joining today were already, a lot of you were already qualified, right? This is just for your learning. But those of you that haven't done your AKT, a lot of you in ST3, you might have already done your AKT, but those that haven't done, remember to get 1 mark in a multiple best answer like this in the AKT, you have to get both options right. You get 1 right and you get 1 wrong, you get no marks. For those of you doing it just for learning, if you get 1 right, 1 wrong, well done. You can learn about the one you didn't get, but at least you knew half of it, right? Okay. So very interesting. The 3 popular answers are E, F, and G, as I would expect, but actually quite a few people picked A and C. Okay, so A, C, quite few people picked either this or this as one of their options. Most of you picked either F or G as one of them. Some of you picked both of these. Some of you picked F and E. Some of you picked G and E. Okay, the correct answers are F and G. So as I mentioned, for those of you doing AKT in the exam, you'd need both to get the 1 mark. If you had one of them right and one wrong, there's nothing. Right? There are no half marks in the AKT. Okay, so anyone know what's the threshold of under typical use? So if you look at effectiveness of contraception, there's often tables where they'll look at under typical use, a real world usage, and then under ideal use, if it was used perfectly. Okay, how many patients would end up with a pregnancy despite perfect use and despite typical use? And like for example, if 1 in 100 would end up pregnant, that means it's 99% effective. If 10 in 100 would end up pregnant, that's 90% effective. Okay. Anyone know what's the threshold for something to be considered highly effective? And see, I've put this in sort of speech marks because it's actually a classification. What's considered highly effective contraception? It's got to be at least 99% effective under typical use to be considered highly effective. All right, because actually nearly everything under perfect use is highly effective. But in the real world, like for example, if someone always used condoms every time and they use them appropriately, they're very effective. But in the real world, sometimes someone will use an external lubricant and it's the wrong type and it might cause an increased risk of splitting. Okay, sometimes it's the wrong size, and again, there's a risk that increased risk of failure. Right, in real world usage. In real world usage, sometimes someone hasn't got one and, it doesn't stop, and therefore that ends up with an unplanned pregnancy. All right. So both of these are more than 99% effective in typical usage. All right. And that's because these are long-term things, aren't they? All right. The progesterone-only injectable, a lot of you picked this. That's actually about 94% effective under typical usage. Under perfect usage, yeah, it's 99%, but that doesn't qualify as highly effective. This bit's important on its own. If you had this and you added to that condoms, then together, that's going to be very effective. But on its own, the progesterone-only injectable doesn't quite reach the threshold. It's better than any of these, but it's not the threshold of 99%. Okay. So let's talk about topiramate. So topiramate's teratogenic and is considered high risk in pregnancy. Generally, if there's any other option, you should go for that. But if there's no alternative, then it can be used with very strict rules. But otherwise, you should avoid it in pregnancy. So if a woman of childbearing age there aren't other options. So if we go back to the scenario, is they tried amitriptyline and it hadn't helped, they're still losing time from work. Why can't they have, what's the other option for migraine prophylaxis? I'm talking generally, not for this patient. What are the three options? So amitriptyline's one, topiramate's one, the other one's a beta blocker, right? We can't give this patient a beta blocker, can we? Because they're asthmatic. And so it may well make that worse. So it wouldn't really work for this patient, right? So that's why they've specifically asked for topiramate. Maybe they know someone who it helped and, you know, it's so bad. And they might not be planning a family at this stage anyway. But even despite that, because they're of childbearing age, you'd only prescribe it if there's a pregnancy prevention program in place. So what does that mean? They need to be using a form of highly effective contraception. Before they go on it, you need to do a pregnancy test to exclude that they're already pregnant. And, you know, if they were early, they might not know. And then you need to make them aware of the risks of topiramate, because if something's 99% effective, it means 1 in 100 they could still end up with a pregnancy. And topiramate can be significantly teratogenic. Okay, so there's risks to the baby. They need to be aware of that. Okay, so highly effective contraception. It means it's 99% plus effective with typical use. So there's 3 that fit this. The copper coil, the levonorgestrel intrauterine system, i.e. the Mirena coil, and then the progestogen-only implant, okay, so the one you have under the skin. However, if they're on that, they need to be counseled that they mustn't take any drugs that could interact and reduce the contraceptive effectiveness, because that could bring it down under 99%. Okay. Whereas, you know, the other things, you know, things like condoms, in typical usage, they're like in the 80% up to low 90s, depending which study you look at. Okay. Things like the combined contraceptive pill, it's sort of just above 90%. You know, progesterone only pill, similarly. The progesterone injections, sort of 94% or thereabouts. Okay. If you look at the UK MEC sort of leaflet on that, all right. These 3 are all 99% plus on typical usage. Okay, so just before we move on to talk about consulting, I just want to summarize this section and then we'll take questions as well. So look, guidelines are changing all the time, right? MHRA updates are really useful. I find it useful, you know, as someone still seeing patients, that just to keep up to date, every so often I'll go on the MHRA website and see what's changed recently. Because some of these things you might not realize unless you specifically look for them. But certainly for those of you sitting exams, it's important to stay up to date for that. And for those of us, you know, consulting to see our patients, you might miss some of these smaller things, okay? Because they don't always make the medical press, if you like, okay? So I want to just really move on to talk a little bit about practical consulting. Then I'll take a Q&A. Before that, just a reminder of the next 5 Emedica events. So we've got a full day MRCGP SCA intensive next week. For those of you sitting in the SCA, all the participant spaces are fully booked. It was fully booked some time ago, but we do have some observer spaces left on the 20th of November. We've got a free SCA study club the evening after that, the 21st November. So the study club, we go through one case, we talk about some specific consultation skills. There's some chance to get involved. It's interactive and you can ask questions. We've got our full day MRCGP AKT preparation course running on the 23rd of November for those planning to sit the exam either in January or April. You might find that helpful. And then on the 28th of November, we've got the orientation session for our AKT Pass Guarantee program. So we have a 3-month program, 90 days, and a 5-month program, 150 days. This is the 5-month, the 150-day program for the April exam. So how that program works is when you're on the program, you'll get regular daily tasks alongside weekly tasks over the period, either 3 months or 5 months. We will have over 225 hours of guided structured learning. We'll cover over 4,500 questions. There's 10 webinars, there's 2 full-day courses, there's half-day stats, half-day admin. We gather data on your areas that you do less well in, and everyone gets their own individual targeted learning plan towards the end. And it's the only program of its kind that has a guarantee. So if you do all the work on time, attend every session, we're so confident that you'll be well prepared that we guarantee. If you don't pass, you can either get a full refund or join the next program and go through everything again and, you know, get you through then, okay? You can choose. And then I appreciate most people are in training already qualified, but some of you might know friends who are applying for GP training. Some of you might be trainers and you've got foundation doctors interested in GP. For those doctors, they need to do really well now in the MSRA because getting into GP training has become hugely competitive. So we have our 2-day MSRA grammar course running on the 30th November and 1st December. You can always keep touch of on the Emedica website, emedica.co.uk. You can scroll down and just see we've got a list of like all of our, for example, if you wanted to join the study club, you can click that. It'll give you a bit more information. You can just click here and register. That one's free to attend anyway. But this is a good way to just keep up to date as to what things are coming up at Emedica. Okay, so practical consulting. I want you all to get involved in the chat because this is such a common issue. Let's say that you're running a little bit behind and you're already a little bit stressed. And now the next patient, patients often they've struggled to get an appointment. They've had to call at 8:30 and go 8:30 and go through the rigmarole of all of that. And they've maybe waited a while and now they're a bit fed up already. And then you're running late. Now, there might be really good reasons why you run late. Sometimes you get a run of patients that have got serious things that need admitting and you're waiting to talk to, bed manager or the registrar and call for advice before you decide if they need an admission or not. And so, there's often lots of reasons why we might end up running late. But that might put us under pressure. We're already a little bit stressed. The patient's already stressed as well because maybe they've got an appointment. They've booked this appointment, but now they're running late and they've got to pick up their child. And maybe they're stressed and they're unwell, right? So it can create a lot of tension. So one of the things that I've seen over the years, and I've been doctoring since 2001, okay, is that actually how you start that consultation, that very first interaction, can have a big impact on the rest of that 12, 15 minutes. So type into the chat, how do you start? Like, what's your opening line when you know that you're already running late? Let's say you're running significantly, you're running 20 minutes late. What would you say first when the patient comes in? Okay, great. So some people will start with something like, sorry for the delay, okay, or just start with an apology. Some people will just go straight into how can I help? I just ignore the fact that you're running late, just get on with the actual consultation because that's what they've ultimately come for. And some of you do what I do, which is rather than saying, I'm sorry for the delay, and can anyone think what might be the issue with that? Now, in some contexts, apologizing is really important. But if they're already a little bit stressed, and sometimes maybe that stress has gone to them being a bit fed up, and then you start with, sorry that I'm running late, or sorry for being late, what do you think might go through their mind? Or sorry to keep you waiting, or sorry, that I'm running late. While you've apologized, you're just highlighting, you're just putting a spotlight on the fact that you are running late. What I do is I instead start with, thank you for your patience. Okay. And when you've just thanked someone, if they were really, really annoyed, right, and they were like, I've had it with this surgery, they make me ring at 8:30, then I'm number 100 in the queue, and then I have to ring back again, and then they say all the slots are gone, ring back tomorrow, and then now I've come on this time, and they're not even running late, and like they're like work themselves up. Then when you say sorry, in their mind, like, I knew it, yeah, they've said sorry because they know that they've done something wrong. Whereas, someone's all that, they're up there, and you say, thank you so much for your patience. How can I help you today? So I'm taking some of the different things that you've said and blending them together, right? That if the first thing they hear is thank you, it's really disarming. It's really difficult to stay angry when someone just thanked you, okay? So what you're doing is you're putting the focus on that they're being patient. So you're highlighting a positive trait. Patience is a fantastic trait to have, right? Do you see, that tends to bring them from here to here. It just helps them to calm down a little bit. And then ultimately, why did they book an appointment? They had an issue, right? So by thanking them, thank you for your patience. You disarm them, calm them down, and then how can I help today? Or what would you like to discuss today? You're now getting into the consultation. And usually then they did have an issue, right? They've got a presenting complaint. They'll then come out with that. And so that can really, I found that compared to if I say, sorry that I'm running late, and then how can I help today? That if I start with thank you for your patience, I found it makes a big difference to the start of that consultation and often to how that, it's a really small change, but small changes can make a big difference to the rest of that consultation. And especially if you're running late, imagine several times, if you can make a small change in each of those consultations, they each go a little bit better, can bring down your stress levels so that you don't end up looking like this. Okay. And that's really what the practical consulting, they're often small things that can make a big difference. Try it. And then when I see you at the next one, let me know how it went. Let me know if it changed some of those interactions. Okay. Great. So we're coming to time now. So, just before we go, please do join our GP Training Support Facebook group if you're in training, or if you're post-training, but maybe you're a trainer or a training practice. Subscribe to our YouTube channel. The video recording of this will be up there by early next week once we've edited it and processed it. But also drop me an email or share in the message section in the chat now what topics you'd like covered in future. We have another one in a couple of months. The GP Training Support Facebook is the biggest group on Facebook for anyone involved in GP training, whether they're applying, whether they're in training, whether they're trainers. We've got nearly 40,000 doctors in the group now. Okay, it's the biggest by a very large margin. And then our YouTube channel, we've now reached over 260 videos on there. So you'll be able to find videos on all kinds of things. So like those that missed the first study club, which was last month, the recording's on there. You can watch that. It's 48 minutes. Okay. We had an AKT high yield revision session. The last orientation was recorded, for those that maybe want to see, maybe that AKT Pass Guarantee program might be for me. You could watch the orientation recording and see, oh, okay, so that's how, because we go through exactly how it works, things like that. Okay. Huge thank you to all of you for joining. If you've got any questions about MRCGP, about GP careers, remember, we're always here to support you. Whatever you're doing, prepare and you will succeed. Thank you so much. I hope you've enjoyed it, and I'll see you at the next one.